A very big hello to all my dear students. So, welcome to the T2O series of ophthalmology, favorite channel, you and I with Dr. Ruchi. So, today again we are going to discuss another very interesting clinical vignette. Let's see whether we can reach the diagnosis easily. Reading, let's read together. A 57 years old male presented with complaints of blurring of near vision. Okay. He has headache. So if just after 40 anybody comes with a difficulty in near vision, we know it's presbyopia. Well, he's 57 years, but he also has headache, he has fatigue, and progressive weakness in his legs. That's significant. On eye examination, his best BCVA क्या होता है? Best corrected visual acuity means after specs correction, the visual acuity was 6/9 in both eyes. Pupils were equal and reactive with no afferent defects. That means optic nerve seems fine. Slit lamp examination revealed bilateral nuclear sclerosis. So I think that must be the cause of 6/9 vision in both eyes because there is nuclear sclerosis. Doing the ocular movement testing, ocular motility testing revealed adduction lag in right eye with associated abduction nystagmus in the left eye. Okay, no adduction, lag of adduction in the right and nystagmus in the left. So whatever is marked in yellow will help you to reach the diagnosis. I think you're already guessing. Convergence is normal. Visual field testing revealed no central scotoma or neurological visual field defects. Neurological defects होना चाहिए. Not okay. Visual field testing, no scotomas and no neurological field defects. The most probable diagnosis. So think with me and let me know क्या होगा. Patient, he is having some difficulty near vision. ठीक है, but nuclear sclerosis है. Difficulty तो वैसे अगर सोचा जाए second sight of old age के हिसाब से this should be actually better, but no, he is having some problem in his near vision. Very significant history is the fatigue and weakness in his legs. You got the point? And look at it, ocular motility is already giving you the answer. There is some problem in his horizontal gaze with adduction lag and nystagmus. No? And convergence is normal. Yes, we are talking about MLF. This is the reason why he is having difficulty in reading because of that adduction lag and there is nystagmus on it. Okay? This motility defect is actually the reason why he's having blurring of his near vision. Okay? And if we can think this way, then we can also relate it because the most common cause of any MLF lesion generally is multiple sclerosis. So the significance, the history of progressive weakness in his legs goes in towards the diagnosis of maybe he has multiple sclerosis. So it's generally more common females, but of course any patient. It is not like specific, any gender can be affected. So that goes towards multiple sclerosis. Right? Okay. So when you're talking about, look at this patient, if we talk about MLF lesion, and can you see on the if I have to read this, I will see that okay, on the right side gaze, everything looks normal. On the left gaze, no adduction here, right? And when there is asked to converge the eyes, this is normal converge, right? So when there is no adduction on the right side means it's a right MLF lesion, already labeled for you. So this is how you should think. Okay? And of course, this is again depicting your internuclear ophthalmoplegia, where when primary gaze, both the eyes are in normal position. In the right gaze, everything looks fine. But on the left gaze, again there's nystagmus and there's no adduction. I think you're familiar with this picture. We have discussed it earlier as well. So this is internuclear ophthalmoplegia. This is a lesion of MLF. And we have talked in detail in our previous sessions regarding horizontal gaze center, PPRF, okay, and how does it work, what is IN and what is 1.5 syndrome. Please revise the previous session so that you are familiar with it. So this is how you are going to logically think when you are solving a clinic, right? Another important thing that I would like to add here to your knowledge is what is INO to ho gaya. You know what is INO? Internuclear thalmoplegia, MLF lesion. Okay, correct. We also know here that the convergence is normal. Convergence is not affected. What is BINO? This is bilateral internuclear ophthalmoplegia. So if the patient looks on this side, this adduction is defective, nystagmus here. When the patient looks on the other side, now this adduction is defective and there's a nystagmus here. This is called bilateral eye. And when there in the primary gaze, the eye is not straight but it is exo. Now you call it the walled eye webino, है ना? Bilateral internuclear ophthalmos. What is webino? It is walled eye where there is primary gaze, both eye there is exotropia. So today you learn two more things along with me apart from internuclear ophthalmos. Right? So thank you so much. Hope you enjoyed the session. Keep studying, keep learning. Okay, stay blessed. Of course, keep smiling.